Welcome back. What we're going to talk about in this lesson is the Anterior Bite Plane Appliance. We're going to talk about the indications for it, but we're also going to talk about the risks of using it. I got introduced to anterior bite planes way back in the 1970s when I was in dental school. I think I made my first Holly bite plane around 1977. It's a very useful appliance, but you do have to be careful with certain aspects of using it. So when we start thinking about anterior bite planes, by nature, they have no posterior occlusion. There's conceptually a number of different anterior bite planes on the market, but they kind of all do the same thing. They try to decrease elevator muscle activity, both in clenching and in lateral motion, by in fact separating posterior teeth. The other thing that happens when you separate the posterior teeth is lateral pterygoid muscles now no longer have to hold the mandible forward, so the lateral pterygoid can release. And then as the lateral pterygoid releases, the condyle typically seats all by itself because of the contraction of the elevator muscles. So anterior bite planes can be very useful appliances when you're trying to deprogram muscles to get bite records in a seated condylar position. Common names, the oldest one would probably be the Holly bite plane. In the 70s came along a modification called the Sved appliance. Holly bite plane used to not cover the incisal edges. It used to have a wire across the labial. The Sved appliance was basically the same appliance but with acrylic covering the incisal edges and no labial wire. And then you've got NTIs and you've got best bite discluders and you've got a number of other things on the market. Some of them only contact central incisors, like NTIs typically are narrower, so they choose to not have as many teeth touching. Typical bite plane actually covers canine to canine. So we'll start with when we don't want to use them, and we've talked about it in previous lessons. If we know that we have a patient who has joint issues, we have intracapsular issues, we have disc displacement issues, we have discomfort from the joint, we don't want to be putting anterior bite planes in because, in fact, we're going to load the joint more. And so we don't want to do things to that joint that potentially increase load and increase symptoms. And so anytime I have a question mark about a patient's joint, unless I'm using the bite plane intentionally for diagnostic purposes to really try and identify if the joint's the problem, typically I would always use a full coverage appliance in any patient that I suspect has abnormal joints. The other contraindication to it, and I tell people this, is if you wear the anterior bite plane and within 30 minutes or an hour your pain is getting worse, take it out immediately and do not put it back in. That normally is indicative, most of the time, of a joint problem that you didn't diagnose. And so for me, a patient who can't wear a bite plane is almost always a patient that I didn't diagnose the joint correctly from my exam. So just so you can see how to talk to patients about an anterior bite plane, since you're watching these videos, you're part of our online membership. And one of the most powerful things that comes with your online membership are patient education videos. And so I just want you to see the patient education video that I would use so I could talk to a patient about the purposes of using an anterior bite plane.
To help minimize tooth wear due to grinding, reduce muscle pain and tension, and diagnose muscle and joint pain issues, a removable appliance called an anterior bite plane may be recommended. An anterior bite plane is a small appliance fabricated by your doctor that is placed on your upper front teeth, creating a platform on which your lower teeth can sit and glide. It is typically worn while sleeping, but can be worn during the day, typically not to exceed 8 hours. While creating a platform for the front teeth to touch, the appliance prevents the back teeth from touching, protecting them from wear and minimizing stress on the jaw muscle. In addition, an expertly constructed appliance will help put the jaw joint into its most natural resting state, allowing you and your doctor to evaluate the extent of the disparity between that position and your current bite. In the right circumstances, an anterior bite plane is an excellent choice to help decrease clenching and grinding and virtually eliminate the tooth wear caused by it. It can promote the longevity of your natural teeth and reduce the need for extensive restorative dentistry in the future.
So for me, using a simple patient education video like that instead of me trying to describe everything is just a much more effective tool. And so I want you to see that we have those videos, because oftentimes dentists who are part of our membership don't realize that they're there. But you could have your team showing that video, you could be showing that video, but it very succinctly describes what an anterior bite plane is. Now, what are the risks of using anterior bite planes? The biggest risk typically is developing an anterior open bite. In those 42 years, how many anterior open bites have I seen from anterior bite planes? I could count them on less than both hands, maybe 6 or 8. And I'm going to show you in later lessons what I did to close those open bites. But an anterior bite plane for me, if a patient has healthy joints, is a really effective appliance to wear at night for protecting teeth and porcelain. But as I said, it does have that risk. What are the things we do to reduce that risk? Well, one is we limit the amount of time they can wear it. So I don't want a patient wearing an anterior bite plane more than really 8 hours, 10 hours a day max. Typically, I prefer they only wear it at night when they're sleeping. And this is an example of what can happen. This happens to be an NTI. This patient actually did not wear this excessively. This is a patient who actually, the problem with this is just because we have an anterior-only appliance doesn't mean patients stop clenching and grinding. And if you keep clenching on an anterior appliance, you can actually intrude the anterior teeth. It's a higher risk in patients with smaller contacts, like this NTI only touches those 3 lower incisors. But if this patient continues to clench, they can actually intrude those teeth over time. And that's exactly what happened to this patient who wore this appliance only at night. And so developing anterior open bites is a risk with anterior appliances. It's one of the reasons I make them go canine to canine. I always have them contacting at least the 4 incisors, typically all 6 anterior teeth, because I want to minimize the risk of this happening. Because just because you make an anterior appliance doesn't mean that the patient is going to stop doing what they're doing in terms of their clenching activity. And so the risk really is eruption of the posterior teeth, intrusion of the anterior teeth. Usually that risk occurs because they're wearing it too many hours a day. But in this case, it occurred because the patient's muscles kept doing what they were doing. The other reason for developing an anterior open bite with an anterior bite plane is what we call mandibular repositioning. And simply put, in a patient whose condyle is significantly down and forward when their teeth fit, so their MIP position, their intercuspal position, is the mandible's quite forward. What happens in those patients is if you choose to give them an anterior bite plane, but it actually happens with any appliance, but happens faster with anterior-only appliances, is when you put in the anterior appliance at night so that now their posterior teeth don't touch, the lateral pterygoid, which is contracted to hold the mandible forward during the day, that muscle starts to get stretched and finally it releases. And when the lateral pterygoid releases, it allows the condyle to seat. Now the mandible goes into a more retruded position. When you wake up in the morning, you take out your appliance, and what normally happens in most people is as soon as they close, they notice their bite doesn't fit. They're typically hitting a posterior tooth. That immediately triggers the lateral pterygoid to move the mandible forward, and they go back and find their original MIP, their original bite. But in some patients, that doesn't happen. In some patients, when the pterygoid releases, their pterygoids don't reprogram. And in those cases, they come to you literally with an anterior open bite. And this happens if you're an orthodontist or you treat patients doing ortho. This can happen simply by taking a patient that looks like they're a class 1 occlusion to you. You put your orthodontic appliances in, they come back at their first 4-week or 6-week interval to see you, And all of a sudden, the patient that looked class 1 looks like this with a big open bite. It's just the mandible repositioning. When the lateral pterygoid releases, the elevator muscles will seat the condyle, and the mandible will go back and up. What we have to do now is figure out, is it possible to get them back into their old position? Or, in fact, are we better off, because they're more comfortable once the pterygoid's released, do we, in fact, now create a new occlusion in a seated condylar position? But essentially, that's what mandibular repositioning is it's the patient who cannot find their old occlusion, the mandible stays retruded. Now, how can we identify who would be at risk of this? Because it's a very specific patient who typically is at risk of this. And the person probably with the greatest risk is the patient who has a very large shift from a seated condylar position into their intercuspal position. It's very easy to measure and evaluate at the exam. What we do is we ask the patient to bite. We use a probe, and you'll see this in upcoming lessons. We ask the patient to bite. We use a periodontal probe, and we measure the overjet of their central incisor. So let's say the left central, measure the overjet from the left central maxillary tooth to mandibular left central. How many millimeters is it? Then I would typically use a leaf gauge to help deprogram and get the condyle seated. I slide the leaf gauge off onto the right central. Once they go forward, back, squeeze, and I know they're comfortable there, I now measure the overjet with the condyle seated. If you see a shift forward, anterior shift of 3+ millimeters, to me that's a high-risk patient who may in fact reposition on you. But it's true, they could reposition even with a full coverage appliance. And they could reposition even if you prep their second molar for a full crown. So at the clinical exam, we recommend you always measure the shift, not because you're going to treat the patient's occlusion to centric relation. You measure the shift to assess risk. Typically, it takes less than 60 seconds to do that. Who else is at risk of repositioning? Patients that have very poor fitting intercuspal positions. So when somebody says to you, when you tell them to bite, they say, I don't know where to bite. That tells you their teeth don't fit well. Same, when somebody says, you tell them to bite and they say, well, which bite do you want? You want the left bite or the right bite? It's telling you their teeth don't fit well. So anytime the patient's occlusion doesn't fit well, those are patients at risk of repositioning. Now here's the good news. The typical patient you see, the shift, if you measure it, is 1 millimeter, maybe 1.5 millimeters. What that tells you is, in fact, it's so small, the condyle just can't move that much. So the risk of repositioning is very small in those people. It's high when we see these big shifts occur. Now, if this happens to you, what do? You have a couple of choices. One is they're not able to find their old occlusion because they're now biting on their back teeth. One way to try and help them find their old occlusion is have them go forward into an end-to-end position and see if they can find it by sliding backwards. So have them bite on their centrals and slowly slide back. Sometimes they'll actually find their old bite that way. In reality, if you were treating the patient because they were having facial pain and they repositioned on you and now they're more comfortable, then what you probably should do is continue deprogramming that patient until you get the muscles released, mount a set of models, and make a decision about where you're going to go next. How will we get the bite to fit when the condyles are in that seated position? So as an example of it, this is from one of our former visiting faculty, Mike Melkert, and this is a patient that was referred to Mike after she had repositioned. And she repositioned on a full coverage appliance. So the history was she was having muscle pain. Her dentist made her a full coverage appliance. After a week or so, her bite changed because her mandible went back as muscles relaxed. She went back into the dentist because the bite didn't fit. He re-equilibrated the appliance. A week later, the bite doesn't fit again. He goes back, re-equilibrates. This happened for several weeks, I think 6, 7, 8 weeks in a row. He kept adjusting the full coverage appliance as she would go farther back. And finally, her open bite was so significant, he referred her to Mike. Mike actually, because she's comfortable, finished deprogramming her. He used an anterior appliance to finish deprogramming her. And then what he's going to do is he actually mounted a set of models. So that's her bite right now. And now he's going to try and figure out, how do I get her teeth to fit? Do we need ortho? Do we equilibrate them? Do we restore them? Do we need orthognathic surgery? But you do all that on mounted models. That's how you test it. Mike took his mounted models and he discovered he could get her front teeth together, but he basically had to amputate all the cusps of the posterior teeth to make it work. And she has no restorations, so there's no way he's going to equilibrate this patient. Instead, he sent her to an orthodontist, and the orthodontist, using some mini implants, intruded posterior teeth, and the patient went from what you see on the left to what you see on the right. And Shannon Magnuson was the orthodontist. Beautiful final result. The condyles are now seated and the teeth fit and the patient's comfortable. So that's really the biggest risk with an anterior bite plane, is development of an open bite. If you check the shift first, you'll pretty much identify who that patient is in terms of their risk level, and realize as long as you limit the appliance wear to 8 hours or less, your risk is not very high of developing the bite plane either, or developing the open bite. How do we make them? In our occlusion workshop, we teach you how to make them chairside. I've made bite planes chairside for probably 30 years. We just need an upper model. We press 1.5 millimeter splint biacryl onto that upper model. You then air abrade the anterior with aluminum oxide, paint any dent and adhesive you want on it, and then put composite on it. For years we used tooth-colored triad. Now there's some beautiful clear composites available. And so very simple, you can make one of these roughly 15 to 20 minutes. Your assistant can make it. And then you just go in and basically evaluate it. And that's all it is. It's just a flat plane with even contact from canine to canine on the bottom. If you want, you can take the canines out of the occlusion, which was what the NTI people would do. I typically don't do that. Now, if you have a patient who wants to wear it more than they should, I have a few. What I do for them is I do a 1 millimeter splint biacryl pressing on the bottom. It's kind of like an Essex retainer orthodontically. And now I have that against the upper. So now we've got basically orthodontic retainers on the top, orthodontic retainers on the bottom, and the only occlusions in the anterior. And then finally, if you in fact have a patient who's got really kind of wacky anterior tooth position, malaligned teeth, over-erupted, under-erupted teeth, sometimes we do what's called a little stylus, where we make a flat plane on the upper, and on the lower, we just add some composite over the centrals and then press the base plate. And so this would be an example of kind of a not easy anterior relationship to work with. So you make them a stylus like that, and now they can slide all over on the bite plane. It's a very, very rapid appliance to make because there's no adjustment. You just make the upper perfectly flat, you make the little stylus extend up, and you're done. Where do I use an anterior bite plane? I use it diagnostically. So for me, if I can't tell for sure from my exam if their discomfort is joint or muscle based, but I don't think it's joint, I actually think it's muscle, I will use the bite plane to confirm that. If I think in fact it's joint based pain, then in truth, you would be better off getting images done of the joint, which would then show you what's happening in the joint, instead of taking the risk with the bite plane. When else do I use an anterior bite plane? To deprogram muscles. I typically will have a patient wear, again, patients with healthy joints. I'll have them wear an anterior bite plane at nighttime only for 2 weeks, and then come in the office, take it out in the morning, brush their teeth, put it back in, come in the office with the bite plane in place, and then I go ahead and make their bite records. And then finally, if I'm just trying to protect teeth from wear or fracture, and they have healthy joints, and I'm mostly worried about nighttime issues, then again, I'll use an anterior bite plane. So those would be the 3 times I would use it. If I suspect joint problems at all, I wouldn't use it. If the patient is going to try and wear it too many hours a day, full coverage is much safer. So yes, I like anterior bite planes, but I do recognize they have significant limitations in terms of the patients you use them in. So some takeaways for you, if you will, some take-home messages. Anterior bite planes can be very effective for deprogramming muscles and treating muscle pain and protecting teeth from wear. If a patient has discomfort wearing an anterior bite plane, it probably means there's a joint problem you didn't diagnose. Anterior bite planes are really well tolerated. What that means is people wear them. One of the problems with full coverage appliances is oftentimes patients don't like them, so they don't wear them. If the patient doesn't have the appliance in, not good. And then the risk of developing an anterior open bite from tooth position changes or mandibular repositioning. So I hope all of that made sense for you. And in the next lessons, we're going to move into full coverage appliances. So I'll look forward to seeing you there.